Everybody, good morning or good afternoon, depending on where you are in the country. Thank you very much for joining us. For those who I do not know, I'm Sandro Galea. I have the privilege of serving as chair of the board of ASPPH, and in that capacity, I am going to be moderating today. Thank you, everybody, for being a part of this. This is our closing panel and discussion of the SPPH virtual annual meeting. As I think everybody knows, the annual meeting was initially planned, as were all meetings all over the country and all over the world, as being an in-person meeting. And we converted it to virtual out of necessity due to the coronavirus pandemic. Despite the unexpected conversion to virtual, the program has been truly a terrific success. I will at the end tell you some numbers and some metrics just to give the audience a sense of the scale of the conversation in which you have been involved. I think it's been a rich, really interesting set of programming. Attendance has been really outstanding. And I want to formally thank Dr. Laura Magana and the entire staff at ASPPH who have brought us together during this time virtually in a way that really, I think, far exceeds all our expectations and has taught us how we can truly have conversations from a distance, making sure that we continue the public health conversation at a time when it's more important than ever. Today, we were planning and hoping to have as a keynote speaker Dr. Anthony Fauci, director of the NIH's National Institute of Allergy and Infectious Disease. Dr. Fauci was called away at the last minute to the White House on an urgent matter. I actually believe you can actually see him on TV with President Trump right now or a few minutes ago. We are deeply grateful to Dr. Fauci for his continued leadership during these unprecedented times, and we will have him back to share insights in the near future. We are today instead going to have a panel of distinguished leaders in academic public health. We are truly grateful to have with us three people who have been deeply influential in public health in the country and across the world. Going from left to right, we have Dean Donna Arnett, Dean of the University of Kentucky College of Public Health, Anna Diaz, Dean of the Drexel University's Dornsife School of Public Health, and Dean James Curran, Dean of the Emory University Rowlands School of Public Health. So the format we're going to take for this session is we're going to ask each of our panelists to speak for 8 to 10 minutes. We'll let them all speak, and then we'll have a moderated Q&A. You may submit questions through the Q&A feature at the bottom of your screen. And once we finish with each presentation, I will do my best to get to questions and moderate a conversation that way. Just a few housekeeping notes. We will be recording this session. It will be posted on the ASPPH website a few hours after the session is over. We also have closed captioning. You can hit the closed caption button on your Zoom control panel. And please feel free to submit questions anytime, and I will do my best afterwards to synthesize and put forward the questions in sequence. So without further ado, we're going to proceed, and first up is going to be Dean Donna Arnett. Donna, over to you.
As you mentioned, this is an unprecedented time in public health and a once-in-a-century event for us to really learn and to move forward the best way that we can in public health. So it's public health's moment, and I think a great time to be in academic public health. So we were asked to comment on lessons learned, challenges, opportunities, and the road ahead. So the challenges have been many. But to start off with, I just want to commend our schools and programs in public health. You know, in the middle of most of our semesters, we had to turn on a dime and create an innovative and online platform for educating. And I'm sure others around the country have done that and done it remarkably well and in a very nimble way. And it's just been a great time to be a public health educator. But we have learned a lot during this pandemic. So one of my key lessons here in Kentucky is that academic public health really needs to be standing hand in hand with local, state, and federal health as we go through these emergency conditions like the COVID-19 pandemic. So what I mean by that is we have to be working side by side. We have stepped up and helped our local health department. We've worked with our state authorities to help them understand modeling, but academic public health really synthesizes and creates more knowledge when we're able to work side by side with our public health practitioners. The other key lesson that we've taken from all of this is that pandemics don't function in isolation. It really requires systems thinkings to deal with these kinds of pandemics. So for instance, we went into what everyone now knows as, flatten the curve. And we instituted many, many, many different public health interventions to the entire public. And so that has had a really beneficial impact on mortality and also on disease rates. And we know that those measures have worked. There's new evidence that just came out yesterday from University of Kentucky showing the differential impact of those various social isolation measures. But that said, we're not functioning in isolation because we shut down our economy. 33% of Kentuckians are now without jobs. 27 million Americans are now without health insurance because of a loss of a job. 30% increase in Kentucky in domestic violence in the last 2 months. So it really takes a measured, thoughtful response that integrates both academic public health with public health practice, as well as the larger business and nonprofit sectors of the economy. So we really need to think more, and as we endure this pandemic until its end, it's going to take that integrated systems level thinking that public health is really, really good at doing. The other interesting challenge, very sad challenge about this pandemic is it's really laid bare the dramatic health inequities in our country. We've had the necessary workers tend to be minority workers, tend to be of lower income and have to go to work in order to maintain their livelihood or be forced into work because they work at grocery stores or those deemed necessary areas. And it's just really further emphasized the health inequity in this country. And I think the other thing that it's really taught us is that we do have a truly broken, fragmented system, not of healthcare, but from both the public health all the way through the healthcare continuum. We have this fragmentation. And really, we need to now move into a point of having universal healthcare as a fundamental right for everyone. So in terms of challenges, there's many challenges that we face locally, and I'm sure you face in your areas as well. We often, in schools, in colleges, but also in local and state health departments, function in silos. So trying to get organizations to cooperate has been very challenging. Here, if you look at our death rates, they're highest in those who have lived in long-term care facilities. Almost 60% of our deaths are in long-term care. And so you have differing people overseeing those. It's not integrated with the rest of the health system. Initially, they weren't allowed to come to the hospital. Then they were sent back to their long-term care facilities while they were infected, resulting in mass infections. Then we also have all of the prisons. So any places where we've had these really concentrated groups of people living together has resulted in more infection. And that's been a real challenge. How do we integrate and be able to communicate well with each other? And then another huge challenge from my perspective too is that we have fragmentation in communication between the federal, the state, and the local governments. And so instead of being able to create solutions together, working together in partnership, it's been a lot of hand waving and finger pointing about whose responsibility is it to test, whose responsibility is it to create masks and distribute them. And in Kentucky being a lower affected state, we've been unable to get testing until the very end. Just now, we're really now getting testing ramped up. So, how do we coordinate federal, state, and local areas? That has been just a huge challenge. And then along with that, we have the whole supply chain of getting supplies, getting food, getting testing delivered. All of that supply chain requires us to be partnering with people that in public health that we haven't partnered with historically. So I see, though, despite all of these gloom, a lot of opportunity. I mean, we've already far exceeded our applications for the fall semester at the bachelor's program level. There's just a real hunger now for public health, and I think it is our moment to really shine. Another area that I think we in public health should embrace is we ought to become those entrepreneurs. We knew that we needed testing. We knew we needed antigen testing. You know, we ought to be able to create those partnerships when we're not in a pandemic, so that we can build up entrepreneurially systems that we can solve those supply chain problems by working in partnership. We also will probably see a lot of changes in the way we investigate pandemics and go through identification of the cases, but not only the cases, their contacts. And so there's already a lot of work going on with Verily under Rob Califf, and that's the subsidiary of Google, really looking at how we can use people's online searching and other methods to track where the epidemic is really centralizing in that moment. So I think there's going to be a lot of opportunities in how we evolve in the whole space of contact tracing. The road ahead, I think, it's going to be a long slog. I think you've heard that before. But for public health, I think it's really, and academics opened up the opportunity for us to really create more creative solutions to delivering public health courses and content in a new way, not only online, but looking at hybrid ways to deliver content. I think also it's time now, if you hear nothing else that I say, it is time for public health to be viewed as an infrastructure for our population. It's no better time to realize that just in 2019, we spent $686 billion on our military and defense, and 7 to 8 billion at CDC, 100-fold difference. If you aggregate all of the deaths between Iraq and Vietnam, they still are lower than the 86,000 deaths we've had from COVID-19. So it's time. It is time for public health to become an infrastructure, to be viewed with the same veracity in terms of protecting our public that our military is in protecting our country. So I will end with that, because it is my passion that we find a way to pursue this public health infrastructure as a right for our states and our communities. Thank you, Sandra.
Thank you, Donna. Next up is Dean Anna Diaz-Rue, Dean of the Drexel Dornsife School of Public Health. Anna.
Sure, thank you. It's really a pleasure to be able to share a few reflections with everyone on this unprecedented situation that we're all living through. And I think many of my comments will parallel some of the things Donna has said. So I've organized my comments into three sort of buckets. I'd like to start out sharing what I see as sort of a few notable features of the pandemic that I think have important implications for the future and for public health. Then I want to talk about something that I'm going to call for now the elephant in the room, and then finish up with some reflections on what's next, what the future trajectories could be. So in terms of a few notable features of the pandemic, there are four that I'd like to highlight. The first is that the pandemic has really highlighted the challenge, but at the same time, the imperative to act based on incomplete information and uncertainty. This is something that we are grappling with in the case of this pandemic in particular, because of the novelty of the virus and its quick progression, because there's so much that we don't know. But it's true of many public health challenges. At the same time, I think what we've seen in the context of this pandemic is how challenging it has been to get organized so that we quickly gather the information that we need, the evidence that we need to understand what's happening and what the best way to act is in a coordinated and timely manner. And this is something that I'll return to. A second notable feature related to this last comment that I was making is I think the pandemic has really made it clear how, for many public health problems, certainly for this one, but I would say that for many others as well, it's critical to have national coordinated responses. And I would go in so far as to say that increasingly global coordinated responses, because obviously this virus does not respect any administrative boundaries from county to county or state to state or country to country. But I would argue that the need for national and global coordinated strategies is increasingly important for many, many different public health issues. One really, striking example of the limitations of not having a coordinated response has been the many challenges we've seen in the allocation of resources. In situations where the usual market allocation mechanisms just can't work in terms of matching up resources with demand. And we've seen this dramatically illustrated in the case of tests and in the case of PPE, for example. But this need for coordination is not just about distributing resources, it's also, again, about information gathering, about coordinating, collaborating and coordinating in obtaining the data and the evidence that we need to act in an evidence-based way. And also, and this is, I think, particularly important in this next phase, to implement data-driven strategies also in a coordinated way to start lifting the social distancing restrictions, for example, and then systematically evaluate those things, because I think we have an opportunity to really learn about what works and what doesn't and under what conditions it works. But the only way we're going to do that is if we implement even these new stages and in eliminating some of the social distancing rules in a way that is systematic and coordinated so that we can all learn from it. The third notable feature of the pandemic, and I think Donna also alluded to this, is that it has made very clear the critical role of having public health infrastructure in place. This is resources for government public health. I think this has been starkly illustrated by this pandemic. I think we're going to see this even more as we go into the next phase when case identification and contact tracing will become critical, because obviously this virus is not going to go away anytime soon. And so we're going to rely on case identification and contact tracing for a while to keep this under control. And for that, infrastructure is critical. And here I think there are also lots of opportunities to leverage the resources and expertise of academic public health. I think there have been some examples, as Donna noted, of collaborations and things that we have done together, ways in which academic public health has supported government public health. But I think there's a lot more opportunity there and a lot more that we could do. And the fourth notable feature of the pandemic, and this perhaps is one of the most striking ones, I think, for me, has been the sheer magnitude of the global response, the global and collective response. In many ways, what we have seen really is a truly unprecedented prioritization of health over the economy. And I think only an infectious disease pandemic, something that everyone is scared of because they could get it in some ways, could accomplish this. None of the other silent killers that we are familiar with in public health, sadly, millions of deaths attributable to air pollution and road traffic fatalities, hundreds of thousands of deaths related to firearms, the impacts of climate change, none of this was enough to motivate collective action of this magnitude. And I think, it's an opportunity to reflect on that and think about what we can learn from it, and simply the fact that this collective action is possible for health. And of course, obviously the things that we have implemented, the social distancing and all the economic implications of that, this has had many adverse impacts on economic, social, and mental health potential, social things, and mental health potentially, physical health because of people perhaps not getting care for other conditions, impact potentially on things like domestic violence, and also a lot that we don't know about the impact that it's having on other health-related things like people's diets or their physical activity, how much they're smoking, etc. So there's going to be a lot for us as social scientists and as public health scientists to study about this. But at the same time, we've also seen, I think, some silver linings despite some of the unintended adverse consequences. We've also seen glimmers of ways in which perhaps we could live and be organized differently. We've seen reductions in air pollution, in carbon emissions, in traffic. We've seen payments to individuals, reconsideration of whether incarceration, of whether some people really need to be in jail. We've seen increases in people consuming locally as opposed to transporting produce all over the world. So I think this is interesting to think about these sort of silver linings, things that we have seen as potentially health promoting aspects of the social distancing and the other strategies that we've implemented. So those are my four notable features: the need to act based on incomplete evidence, the need for a coordinated national and global response, the critical need for public health infrastructure, and the sheer magnitude of the global collective response. I'd like to turn now to the second topic I wanted to touch on, which was what I call the elephant in the room. And for me, this is how the pandemic has shown us once again the critical role of social structure, economic factors, racism, environment broadly defined in health. And we've seen this manifested in the inequities that we've seen across people in terms of testing and cases and mortality, but also increasingly, I think we're going to see it across countries. And we're starting to see some of that, but I think it will become more and more evident as the pandemic spreads to lower and middle income countries. We've already seen some early previews, unfortunately, of that in cities like Guayaquil in Ecuador, Mumbai in India, and many others. So this will become more and more evident. These inequities will become more and more evident, I think, as the pandemic advances and in the next phases, where as we lift some of these social distancing strategies, perhaps in the higher income countries, it's very possible we're going to see the virus cluster more and more in disadvantaged populations. And these, this is no surprise. Social and economic structures have been fundamental drivers of many epidemics, including AIDS in the 1980s, the opioid epidemic, and will today strongly affect the impact and evolution of COVID-19. More generally, the pandemic and also our response to it has made very visible and concrete the links between the social, economic, and political systems we create for ourselves and our health. And I think this is obviously something that we've known in public health and highlighted for a long time, but this is an incredibly powerful example of this. And I think the attention that we've seen in the media and in the public on these issues is really an opportunity for us to think about the implications that this has for other public health problems that are still there, not going to go away even with COVID. And my last set of comments has to do with this, what's next? I'd just like to touch on sort of two potential pathways that could evolve as a result of this, and perhaps we'll end up somewhere in between. But one pathway is that we return to business as usual with COVID added to the mix. We return to our regular lives with more social distancing. We retreat to our cars to avoid public transportation. We reconsider living in dense cities. We make no dramatic changes to eliminate the inequities that were made visible, even more visible by this pandemic. That's one option, and it could very well happen. Another option is to envision a new approach to public health, an approach that's more coordinated, more supported, that leverages our resources and our knowledge more efficiently and more effectively. That's more integrated, that we see infectious and chronic diseases as really combined and that we need to look at them together. COVID has made that very obvious. We also need to look at how interactions with environmental factors, we've seen that environmental factors could potentiate the effect of the virus. And also that things like social policy, labor policy, and healthcare policy are all interconnected. And lastly, perhaps in this alternative scenario, we as a society would be more open to re-envisioning what a healthier society could look like. Yes, with effective vaccines and treatments for COVID-19 and ways to develop these quickly in the case of future pandemics, which we know may happen, and healthcare for all, but also thinking about ways that we could live with less cars, more open public spaces, less air pollution, equity and access to sick leave and decent housing, increased emphasis on local consumption, less travel perhaps, and less inequities. So I think the jury is still out in terms of what pathway we're going to take, but I think we have an opportunity perhaps to see what a different future for public health could look like after this pandemic. Thank you.
Thank you, Anna. That was actually, Anna and Donna's talks were really complimentary. Terrific. Thank you. Next up is Dean Jim Curran, Dean from the Emory Rollins School of Public Health. Jim, over to you.
Thank you, Sandro. I'd like to, first of all, agree with everything that Dr. Diaz-Rue and Dr. Arnett said. I thought they were very visionary, thoughtful comments. This is indeed the public health pandemic of the century, and it's taken the world by surprise and the United States by surprise and every part of the world by surprise. All of us will remember where we were, what were things like before COVID and what things will be like after COVID. It's going to be World War II-like as an experience for society. Of course, that makes it a great opportunity to be in public health because public health is at the center of the universe right now. And people who work in public health must work on COVID. I wasn't going to do this, but I spent about 60% of my time working on COVID now. My daughter's at CDC working on something else, and all of CDC wants to work on COVID because this is the public health pandemic of the century. Tony Fauci and I have known each other for 40 years, and I'm the disappointing substitute for interviewing Tony. I had questions for him, many questions that people sent in. We were doing this together 40 years ago in the beginning of the AIDS epidemic, and I was suffering like he suffers. The difference is that he's so good at this that he's been doing it now for 50 years, and he remains, to me, the most accomplished scientist and public health leader and spokesman that I've ever seen in my lifetime. I've never thought of him as looking like Brad Pitt, but other than that, I think he deserves all the praise he can get. And I suspected that he would be called away for this session because that's what happens during this time period. We talk a lot about public health and politics, and I always say it shouldn't be partisan during an epidemic, but it clearly has been here. And I'm not fettered by working for the government like Tony. So I won't be as good as Tony, but I will be more candid than Tony in what I have to say, because I can be. I think that the whole problem starts with, well, in addition to the problems that have occurred, with a misunderstanding of what we're trying to do. An infectious disease epidemiology, and this is where it's a little bit like AIDS. We're really trying to do two things. We're trying to save the lives of the people who are infected, and we're trying to prevent transmission of infection. So everything we do should be thought of in the terms of, does this advance this or does it not advance this? Now, because of scarcity, a lot of our policies were defined by priorities rather than by what they should be. So, for example, we need to have enough test kits, and people were dying because they didn't have enough ventilators. So we made policies at the state, local, and federal level saying, well, you don't really need to be tested if you have flu-like symptoms, because we were saving the test kits for the people who were dying and the healthcare workers taking care of them. What we should have said was, you absolutely need to be tested, and all your contacts need to be tested because you need to be isolated and prevent transmission from other people. But we didn't say that because we're afraid to say we just don't really have enough tests, and we're going to prioritize saving lives over preventing infection. After that, when we finally get enough tests, we treat it like it's a commodity chain. Okay, what we got to do, you need more testing. That is what we want to do. What we want to do is find positive people and isolate them. And the test is just one part of that. So we concentrate on producing more tests. Then we concentrate on producing better tests. These things are important. Then we ship them out and we find out they don't have enough reagents. Oh my goodness. So then we get the reagents. Then we find out they don't have enough machines. Now they got the machines, but they're in the wrong places. And now we're going to say, now we got plenty of machines and plenty of that. What are we going to do with it? We're going to test everybody in the country. No, we're not going to do that. We're going to prioritize testing, and we're going to do contact tracing, all to identify infected people, isolate them as soon as possible, and interrupt transmission. But that still isn't even the message. So pardon me, this is, believe me, it's seasonal allergies. So it still isn't even clear what the purpose of all this testing is for. And what it is, of course, is this is the direct targeted intervention that makes all of the mitigation efforts more effective. If you socially isolate, you're socially isolating from infected people who don't know they have it, who are still transmitting. If you could find half of those people and isolate them, you would double the impact of social distancing. And no one even knows that, because we've talked so much about all we do know about social distancing as if it's an intervention which is so specific we can predict what's going to happen if a few hairdressers open up. Because we haven't focused, we've forgotten the main principle of prevention, and we still don't know it. People don't know what the contact tracing is all about. So if you compare AIDS to COVID, what's good and bad about it? Well, obviously, there's nothing worse than a respiratory virus which kills people and can be transmitted from person to person around the world very, very fast. So it's almost not a comparison. But there are some good things as well as bad things. The transmission is obviously much, 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 much worse than it ever has been with HIV. But the science is also much better. Within a few short days to a week or so, the virus was not only isolated, but its genetic sequence was published online around the world. It took almost 2 years for that to happen, or 3 years with AIDS and HIV. We both began surveillance with deaths. And really, the only reliable, semi-reliable surveillance that goes on now is with deaths and hospitalizations. The number.
Jim, you've gone onto mute. I think you're still on mute. Hold on, Jim, you're still definitely on mute.
Hi, that better?
Yeah, you're better.
Okay, great.
The last word we heard was hospitalizations.
Okay, well, the only good thing, the only halfway sensitive issue of surveillance are deaths and hospitalizations. The number of cases is at least tenfold underreported. And the argument can be about the number of deaths being accurate. I'm with Tony Fauci. They're almost certainly underreported instead of overreported, but they're probably not overreported by a logarithmic factor. Maybe there's 100,000 instead of 85,000. that's important because the number of deaths is the only real factor that informs all of the modelers. All of the other things are assumptions they make about interventions. But when you change the number of deaths, of course, it changes the number of projected deaths into the future. The second thing is there's still a much not known about COVID. And we always, when something happens, we always pretend like we think we didn't know it. Like, oh my goodness, there's asymptomatic transmission. Well, of course there is. There have been 10 million, 15 million people infected, and most of them didn't know it. And all the testing has been with sick people in hospitals. So we have this bias, like we used to have with AIDS, of thinking that everybody who has HIV is dying. And that's what we're kind of seeing now. Now that serves to scare us, which I guess has some benefits, but it doesn't tell us what's going on with certain populations, like children, for example. Are children only less likely to get sick, or are they really less likely to get infected? Some small studies out of China say that the viral loads are the same in children. Some small household studies say that children in hospitals under 12 are just as likely to be infected as their adult counterparts. If that's true, then what are the implications for sending kids back to school or daycare centers if the transmissibility is just as high? Or will children actually become engines for transmission in society? We're going to learn that really soon, I think, but we'll be surprised as if no one ever thought about it as a possibility. What do we know about immunity? We know that we're learning about how good antibody tests are and how good antigen tests are and how good PCR tests are. And we know that they're going to get better because science is so much better, but we also know they're not perfect yet. One of the good things is that we have kind of a natural vaccine trial going on, and that there's been very little evidence of reinfection. Now, that doesn't mean that you can't get reinfected. It doesn't mean it's perfect. It doesn't mean Tony Fauci would say that once you get it, you never can get reinfected. But, you know, if you've got 10 million Americans infected and all these people throughout the world infected, you know, you'd expect by now there'd be a lot more looking at reinfection. And there's some evidence of continued PCR positivity, but it's likely that this can cause us optimism for my two optimistic points I'm going to say later. The other thing, and this is the main, so I think there probably will be a vaccine, and I would hope that there will be a cure or curative therapy. And I think that remdesivir is a little like AZT was with AIDS, and that just a proof of principle that something might work. And it took another 7 or 8 years with AIDS to come up with a cocktail that actually was quite effective. But AIDS is bad in two ways. One is that it's a silent infection for a long time. 40 million people have died and another 40 million people are still infected. And there's no cure and there's no vaccine. And the immune response told us that it was possible there would never be a vaccine. The immune response with COVID and other coronaviruses is much more positive about developing a vaccine. There will, of course, be equity issues about distribution of the vaccine, but that's kind of down the line. So I'm optimistic about a vaccine. The other thing I think that I'm optimistic about, and this is will sound almost theoretical, is the one good thing about COVID is it doesn't last very long. The very bad thing about HIV is it truly lasts for life. So whatever you do has to be done for life. And the concept of interrupting transmission and eliminating HIV, it's a popular thing to talk about, but it's virtually impossible when you have a lifelong infection. With COVID, the thing to think about is that most of the people who die were infected about 3 or 4 weeks ago. The converse of that is that people who died July and August and September and October have yet to be infected. So if we had a perfect solution right now, no one would die after June. Now, no one ever talks that way because most people don't want to focus prevention enough to find and identify and isolate infected people, which is what really needs to be done. But if you think about it, nobody's going to die in July, August, and September in the United States who are currently infected. The people who are going to die are the ones that will be infected. So what an opportunity to reduce infection rates and reduce death rates. The second thing I think that makes me optimistic, and we've seen this, of course, in Wuhan, China, and South Korea, and China itself. Who would predict a place like Wuhan, where this all started, would get down to 0 infections? It shows that it can be done. Now, of course, their public response, where they take public health and healthcare and make it all one system under direct autocratic control, they have 6 new infections in China, in Wuhan, and they said, okay, we're going to stop this right now. We're going to test all 11 million people this week again and isolate everybody. And they do that. We don't have that kind of political will in the United States to deal with outbreaks. I mean, for example, how is it possible that every senior living center in the United States hasn't been tested and all their staff hasn't been tested and all the positives be cohorted? How is it possible? The same thing with jails and prisons and cruise ships and senior living center. I mean, there's a wealthy senior living center down the street from where I live, where the people are multimillionaires who live there, and they can't get tested. And so they just watch people die who are even wealthy, let alone poor people. How can we let people die in these circumstances? Our solution in prisons, I think it's a good idea to let people out, but we ought to test them first. And if they're positive, we ought to isolate them in a hotel until they're no longer infectious. We have to tie this thing together. You know, I mean, we test people in homeless shelters. We had to put them in a hotel for a month. I mean, the good thing is it's not forever, it's just for a few weeks. And then they can go back, you know, but we have to think about this as a consensus thing that's all aimed at isolating and identifying and isolating infected people and not allowing places to be hotbeds. I mean, why can't a residence hall be like a nursing home? You know, what are we doing in terms of outbreak response as we move back to campus? It's not just testing everybody, but what if there are 3 cases on the floor of a residence hall? Could that become like a cruise ship or a poultry factory in Georgia? What safeguards do we have in place? So it really comes down to testing, contact tracing, and outbreak response, which is old-fashioned epidemiology, and it has to be prioritized. But I'm optimistic about it, and I'm optimistic that we in public health will have a role, and we have to figure out how to help our universities decide whether to come back full-time in the fall, and if they do, what we're going to do to make it a safe place, and then contribute to the rest of society. So I apologize for ranting a little bit. I'm doing it on behalf of Tony Fauci.
Jim, that was great. Thank you. Thank you, everybody. And actually, judging by the questions, I think all panelists have struck a nerve. So I'm going to try to go quickly through a couple of questions. I'll start with one for all the panelists from Amanda, because I think perhaps it's the most important question of all, which is how can public health students and future epidemiologists best shape their studies and mindsets? I like the turn of phrase. Best shape their studies and mindset for a post-COVID world. Maybe we can go through in sequence. Donna, would you like to go first?
That is a big question.
Mm-hmm.
So I think that Jim is absolutely right. You know, you test, you isolate, you contact trace. Those are the fundamentals where I think that we may be able to adapt our mindset and apply some of the more innovative technologies is in utilizing some of these electronic forms of contact tracing. Now, there are all kinds of privacy issues that we will have to deal with. We're exploring a bracelet that our students would wear. It detects anyone that's been in contact with them that also has the bracelet, and it can anonymously then contact people who were exposed to a case. And it does that in an automated way and preserves their identity. So I think that in terms of thinking through how we go forward in the future, I think the mindset needs to be around how we can utilize our newer technologies while still adhering to those fundamental principles that Jim articulated so well. Test, isolate, contact trace, do the outbreak.
Thank you. Anna.
Yeah, that's a great question. I mean, I think one is, you know, and this may sound a little bit like boring, but really get training in the solid basic concepts of public health. I mean, to me, it's been amazing, you know, I'm having my coffee in the morning and I hear this discussion of sensitivity and specificity on the radio of tests, for example, or just basic things like what is an incidence, what's a case fatality rate? And in some ways, and I think Jim was talking about this too, what we're dealing with in terms of the pandemic, it's not rocket science, right? We don't have the information, but the information we need is pretty basic epidemiology in many ways. And so I think getting trained in the basic concepts, solid training in the basic concepts of public health and all the subdisciplines of public health, not just epidemiology, but also social science aspects, also public health practice, et cetera. So that is one piece, the validity of the core public health training, and also this broader systemic thinking, right? How to think more systemically so that you can put all this stuff together and understand the interrelations, which are so critical to the impact, to what we need to do and to the impact of what we do.
Thank you, Jim.
So we used to always say in either WHO or CDC, you should never waste a crisis. And I guess by that, we meant that if you see something that you're responding to, it's really important to take advantage of the idea that this is an opportunity to highlight what public health is and how it can respond to a problem. Recently, an example of that was the opioid epidemic. Opioids, of course, have been a problem for 100 years in the United States. We're a ghettoized problem in the 70s and 80s. But it reached such a high prevalence and widespread thing in society that everybody all of a sudden dropped their partisan views and started to jump on it. And that was important to point out all of the social and social determinant inequities that underlie the public health crisis of opioids. Well, the same thing is true for this. I think it's important for us to realize that it shows a lack of infrastructure for public health throughout the United States, throughout the world, that it's exactly the opposite of what Donald Trump says. It's something where we should strengthen the World Health Organization and other ways to collaborate with each other. Well, we should work together as countries, avoid nationalistic tendencies that have been going on throughout the world, because we need to work together to get things done. It may be that the vaccine is discovered in China and it's the best vaccine. We should be thinking about it that way. And then the third thing is for students, I think it's important for them to be very knowledgeable about what's going on. Even if they're mostly interested in reproductive health, they should know about COVID. They should know everything. They should be the ones in their family who their family goes to say, what do you know about this? What do you know about the sensitivity and specificity of this test? Explain what a positive predictive value is, because all of these things have the similar underlying public health principles that we can help other people understand, and we should understand how they apply to the global health pandemic of the century.
Thank you, everybody. If I may just editorialize for public health students, I think I am jealous about the world that you'll be able to build, and I echo all the panelists. Now's the time to really learn it well, and we certainly want you to create a healthier world for all of us. I think we have time for one or maybe two more questions, and maybe we'll go backwards this time on the panel. It's a great question. I think it's from Legis. I'm sorry if I'm not pronouncing the name correctly. What have you learned about the role of science in responding to such a pandemic of global scale so quickly? What have we learned about the role of science at this moment? Jim, maybe you can go first this time.
It's extremely important. It begins with the isolation of the virus and its sequencing and learning the mode of transmission. There's still an awful lot to learn about the natural history and pathogenesis of the virus. From the social sciences point of view, we have an even longer way to go as we start to think about interventions and the implications of those interventions in various communities. And science is going to be pitted against other influences, as it has been in the White House. Now, we have a uniquely blind president at this point. I've never seen a president who's quite so anti-science or ignorant about science. Even Ronald Reagan looks a lot better in some ways than Donald Trump does. And that's a battle that a lot of people have to have. But it's legitimate to have science. Some problems are thought to be too important for public health or too important for science. And we're in that situation now where the economy itself is competing with science and public health. And it's important to recognize the legitimacy of those countervailing views and not say, well, they don't care about science, because I think it's a legitimate countervailing view.
Jim, I think it's fair to say that you said things that Dr. Fauci would not have said. Anna.
Yeah, I mean, I would say two things. I think we have learned that the role of science it continues to be critical, and I think we've seen this in terms of very basic things that we need to know about the virus in order to be able to take the very simple actions that we need to take. And yet there's, a lot of uncertainty still. Some things we know, but there's still uncertainty in others. And I think the other thing that, at least for me, it has made me wonder whether sort of the approach we have to doing science sort of in normal times, which is this kind of entrepreneurial, each scientist is independent and doing their own thing, following their own ideas. I mean, that can be very useful and has led to very useful knowledge. But in a situation of crisis like this, I wonder whether it is the best approach, whether we need some sort of a larger coordination so that our efforts as scientists can be more productive and more oriented and provide society with the information that we really need, as opposed to each of us doing our tiny little study, publishing it in the pre-peer reviewed, then having it contradicted by another study. That has raised questions for me about what is the best way that we need to organize scientific evidence gathering in a crisis like this.
That would be such an interesting whole other hour discussion. Donna.
Well, I agree with both Jim and Anna. I would also say that we have to, I think, science is the foundation of public health. I mean, epidemiology, that's what we learned in our MPH and PhD programs. But the problem is we need to be able to jump into real world settings and utilize those collaborations with scientists outside our field in order to build the best science in a very short time. So I think we need more collaborative and interdisciplinary science as we move forward in public health. And I also don't want us, and Sandra will realize how important this is for me to say, I don't think we ought to just focus on the genetics or the RNA sequence. I mean, the science of the unintended consequences of our public health interventions and doing really rigorous science to understand what these impacts are and quantifying them. I think that's going to be, as we move forward, as important as the basic science of the COVID itself.
Thank you, Donna. That was actually a perfect answer to preface the last question. So we've asked one question about education, one question about science, and maybe for our last question, we can do one about the public conversation. And it builds on Donna's point, because the question is as follows from Kimberly. How can we navigate the public conversation balance between economic sustainability versus preserving the public's health? I think it's just a terrific question. Maybe Donna, you can want to go first on that? Sure,
and it's something that we've thought a lot about here. As I said in the beginning, 33% of our population is now unemployed. Domestic violence has gone up. I mean, it's just been a tragedy in many ways. Is there a way that we can build science very quickly to understand which of our measures were most effective, the challenges that they were all implemented at the same time? So understanding what types of social isolation worked best, we can't really understand. But as we move forward to try to tease apart what is the best solution to allow our country and state and communities to re-engage while protecting the most vulnerable.
Thank you. Anna.
I think there is no contradiction between sustainability and public health. The question is, what kind of economy is health producing? And what kind of economy is health damaging? And what's the balance? So it's a complicated issue, but I think we need to really think carefully about what kind of economic system is the most health promoting, and what have we learned from this crisis about what directions we should be moving in socially, economically, and from the point of view of health.
That is a deceptively radical answer. Jim.
I think this is really, 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 really hard. And it won't be done perfectly, or maybe not even well. I think that the key thing is going to be transparency and trying to get agreement on the facts and the truth, and then let it go from there. In a sense that there'll be a tendency for those who are tired of social isolation and want to open up the economy to either lie or change the public health facts. There'll be a tendency for those people in public health who want to say that overestimate the effect of social distancing and some of the changes in it will make. And I think there has to, if we have to make sure the facts are all agreed upon, and then also we have to make sure that all of society is doing everything they can to help. So I was on a call this morning with businesses, and they all have to provide rapid testing for their employees. They have to provide a situation where if their employees are sick, they can stay home and still get paid. They have to make sure people don't lose health insurance. They have to have social distancing in the workplace. And we have to have everybody kind of working together who agree on the facts, rather than have the facts distorted by one side or the other. And one side or the other is we can't live as a society with 30% unemployment and nobody paying any taxes and just giving trillions of dollars in stimulus away forever. On the other hand, we have to have much more widespread testing and isolation to make anything else feasible. And we're going to continue to have deaths. And the question is, can we live with 2,000 or 3,000 a month? We certainly can't live with 30, 40,000 a month.
First of all, thank you. Those were really outstanding answers. I always learn from all three of you, and I learned from you again today. Thank you very much. Let me make a few quick closing remarks, because as I said at the beginning, this is the last session of our virtual annual meeting of ASPPH. And I just want to give the audience a bit of a sense of how the meeting went. We transitioned to digital. We've had a total of 26 virtual sessions, 76 speakers, 3,000 of you have participated in 50 countries, which has been really remarkable. We always at the annual meeting congratulate our ASPPH award winners. I would encourage you all to take a look at the award winners on ASPPH's website. ASPPH continues to try to serve the academic public health community as well as we possibly can, particularly in a time like this. Today, we launched, as part of the annual virtual annual meeting, a global network for academic public health with partnerships all over the world. We are very grateful to all the sponsors and exhibitors for the general support of the annual meeting. And we are really very grateful to all the schools and programs of public health who have participated in the annual meeting, even while we've all been navigating the impact of the COVID-19 pandemic. We have continued fostering peer-to-peer discussions, communicating information, and generating enormous discussion through our online communities. Looking ahead a little bit, the annual ASPPH annual Sections Leadership Retreat is also moving online in June and July. The goal is to replicate in some respects the success of the virtual annual meeting. We'll continue to provide opportunities to discuss best practices virtually. You can also look online on the webpage for resources from every single school and program on around COVID-19. There's an enormous wealth of information on the ASPPH website. We have also curated a list of Public Health 101 COVID-19 training resources. And last but not least, the organization has been involved in advocacy around COVID-19, including op-ed essays from myself, from the President's CEO, Laura Magana, quite a bit of work with other partnerships in terms of letters and amicus briefs around key issues of COVID-19. We have been engaged with national partners since the beginning of COVID-19, also have been holding virtual career fairs and working with students, looking at students as the next generation and the generation that will be creating a healthier world going forward. And last but not least, before we end, two things. Number one, I would like to thank the ASPPH staff who have made the virtual annual meeting possible. I already thanked them at the beginning, but really the staff at ASPPH hold the organization together. They have had an enormous job at a time like this. And I want to thank them for everything they've done. Much of it is invisible. And I'm here to tell you that the entire staff has been working night and day to make the virtual annual meeting happen and to represent academic public health and to be our voice at this time. So thank you. And 2021, next year, is ASPPH's 80th anniversary. That strikes me as it gives us a really good opportunity, a really good excuse to celebrate as we move beyond the acute phase of COVID-19 to a new world. It will definitely be a new world in 2021, and hopefully one that is leading us on the path to all being healthier. I want to thank again our panelists, and I want to thank our participants, those who participated today and the thousands who participated in the virtual annual meeting. Thank you, everybody. Stay well, stay healthy, and I'm very much looking forward to our next conversation. Have a good afternoon.